Right, hi, morning. Thank you very much for asking me to speak. I'm a chest physician from Manchester. I work at Wythenshawe Hospital, which is the regional lung centre, and I've been doing breath research for about 10 years now, actually. Since Paul Thomas used to work up in Manchester, he introduced me to the subject, and I've gone with it since he left us for Loughborough, but we've been carrying it on up in Manchester. So we do a number of studies in a number of different diseases, but I'm just going to stick to asthma today, actually. Sorry, this is a bit tight. I'm a bit too tall for the lead here, I think. So when I talk about asthma and I talk about potential applications for breath tests in asthma, I'm not really just talking about asthma and not really just talking about breath tests. I'm talking about biomarkers in general, and I'm talking about tests in general. You know, a lot of focus is on diagnosis of disease, but that's not the only area that we want biomarkers for. We did a review article with Leva Boss and Peter Sturt from Amsterdam a couple of years ago. It just got us thinking about what sort of areas we'd like to use breath tests in. And there's varied, you know, from disease prediction, as we've heard already, potentially predicting diseases like asthma, from diagnosis through to exacerbation prediction, again in asthma, you know, who's going to have these potentially life-threatening exacerbations. Phenotyping, which I'll come back to, it's quite a trendy word in asthma and I guess other diseases as well, and means probably different things biologically than it means to us clinically. Treatment stratification, which is linked to phenotyping but slightly different. Treatment response, and then I've added to this figure that we did for the journal, treatment monitoring. It's very important in asthma for us to know what treatment our patients are taking. In asthma, only about 30% of people with asthma take the drugs that the doctors think that they're taking. And you know, it's usually due to forgetfulness and it's not on purpose, but it really affects our ability to treat people properly, and we usually end up ramping up treatment unnecessarily when in fact all they need to really do is take the treatment that we thought they were taking in the first place. So first of all, I'm just going to talk about diagnosis, and I'm going to talk about diagnosis fairly briefly, because again it's seen as an important target for a biomarker, but we've got to think about whether it's feasible to have a diagnostic biomarker in the breath in a disease like asthma, and we've got to think whether it's necessary as well, or whether it's the most important thing or the most relevant thing. So of course, to make an example of this, it's best probably to put one of my own studies if I'm going to criticise the field. So this is a secondary analysis of some data we got from two studies that were done in parallel. We did a COPD study and we did an asthma study, and we were using the same room, the same breath sample. It was done over the same time of the year by the same student doing the studies as well that went into his thesis. Then we did a secondary analysis, and this was a methodological paper looking at the data analytical method. And of course we could see very clear separation between the groups with sort of internal, external validation. So we left out a training set and a test set and then looked at that. So we did get some internal type validation, but we showed very strong differences between the groups. But so what does that really mean? There's a lot of limitations with the diagnostic studies that we see in asthma, and these are common across the board, and this is beyond the limitations of particular breath analytical methods or data analysis methods. This is limitations of the interpretation of the study. The usual problems are that we've got a healthy group of people who aren't patients, who are perfectly healthy, don't have any respiratory problems at all, and for that reason they've been selected as controls for this study. On the other hand, the people with asthma or disease usually have established disease. Sometimes they've had it for 20 or 30 years. They're not the sort of people we want to use a diagnostic test in. We want to use a diagnostic test in people who are presenting with symptoms suggestive of asthma, who we then want to go and look to see if our diagnostic works. Now that's a much trickier proposition than taking a healthy group and taking an asthmatic group. The other confounders include, of course, treatment. So in asthma, the vast majority of people are prescribed inhaled steroids. Steroids have a profound effect on the inflammatory status of the lung, and of course that is going to dramatically affect the test, and that is not going to be the situation if I'm a GP and I'm sat in an office and I want to diagnose the disease. Finally, the control groups are often imbalanced. Sometimes they're a different age, sometimes they've got a different average BMI, sometimes the gender split's different. So for example, in asthma, the majority are female, usually is 50-50 in a control group. We try and balance it as much as we can, but often the control group isn't great. And for lung disease, one of the key differences between the control group is the calibre of the airways. So in asthma and COPD, you have narrower airways, you have reduced airflow, and that's a physical difference between the healthy controls. So we're talking about breath tests there might well be an impact. And I know there's some data suggesting there might not be a great impact, but there might still be an impact if we're looking for sensitive markers of disease between having a group who have, a 20% reduction in flow versus normal flow. Secondly, is it plausible that we can have some sort of biological diagnostic for asthma? The problem with asthma and COPD is they're both defined by physiology. So you have to have symptoms, but they're diagnosed by that calibre of the airway. So in asthma, you have to have variable airflow obstruction. In COPD, you have to have not fully reversible airflow obstruction. They're diagnosed on the calibre of the airway. It's nothing to do with the inflammatory process going on in the lungs. And we know in asthma in particular, and probably in COPD, there are actually lots of different inflammatory pathways underlying it. So if we're looking for some biomarker or group of biomarkers that's related to inflammation, then I think it's potentially fairly unlikely that we'll find that in the breath. And maybe, given that asthma and COPD are already well defined on the basis of physiology, we should leave it at that. Maybe we should be looking in different areas for reasons to use our breath tests. So are asthma diagnostic studies still useful? Well, I would say yes. Again, this is our own data. So these are the 15 compounds that we published in Thorax that could discriminate between asthma and healthy people. It's instructive to look at the compounds. So all of our studies use GCMS because we want to know what the compounds are. 7 of those compounds were related to probably oxidative stress. They were alkanes and methylated alkanes and things that have been published elsewhere. And if we start to look at those compounds themselves, we've got a list now. This has been drawn up by one of my students, and it's a list of compounds that have been reported in multiple studies in asthma as potential diagnostics for asthma. Now, the strength of this, going against what I've said about us not having diagnostic, is now we've got studies from different countries using different sampling apparatus, using different data analysis methods and different control groups that are starting to show the same compounds come up again and again, which to me is a great strength. I mean, Jonathan Beecham's going to speak about standardisation later, and I'm all for standardisation to try and unify what we're doing. But actually, it's a great strength that all these people are using different methods and coming up with the same types of compounds again and again. And actually, speaking of specificity for asthma, Aggie's compounds, some of those in inflammatory bowel disease, were very similar to these compounds. So actually, they're probably likely to reflect more the underlying inflammatory process in general, rather than be specific to asthma, I would think. So the next use, phenotyping. Now, what we mean by phenotyping, I did biology at school, and we learned phenotyping was the expression of genes, outward expression. Well, we don't really mean that in lung disease, and I guess other clinical situations as well. We mean about some sort of expression that we can see, some type of disease that we can say. For example, in asthma, we might talk about eosinophil-driven asthma, or neutrophil-associated or infection-associated asthma. You can also look at phenotyping in an unbiased way. So we might wonder what the breath phenotypes are of people with asthma. Take, in a completely unbiased way, just look at the breath profiles of a bunch of people with a given disease and see if they divide into different groups. And then go look to see if there's clinical differences between those groups, to see if the breath potentially tells us something new. So we did this in UBioPred. UBioPred's a big severe asthma cohort that finished 2 or 3 years ago. It ran across multiple European countries, multiple centres. We collected breath in a very simple way because we had to, because it was done across all these centres. So we collected it using a Tedler bag. Patients breathed filtered air, and then we sampled them onto the adsorbent tubes, which were then sent centrally for analysis by GCMS. Sorry, they weren't. They were analysed by GCMS, but for this study, we analysed them by this composite E-nose, which had several different sensors in, amounting to about 158 data points for each patient. They were analysed by GCMS in parallel, but I don't have those data for you. We used principal component analysis to try and reduce the data down, and then we clustered the data. So we didn't apply any clinical metadata to these at all. It was just the breath signal, and we saw how it clustered in a completely unbiased fashion. We had samples from 78 patients taken from 7 sites across 5 countries. The mean age, which is typical for a severe asthma study, was 56. As I say, usually more female than male. Quite a few smokers, but we took everyone in UBioPred. We didn't exclude any particular group. We just wanted people with severe asthma. Almost half of them on long-term oral steroids, so these are a very severe group of patients. About 2/3 were allergic, and the lung function was on average reduced. So we had 34 principal components with an eigenvalue greater than 1, which were then used in the modelling. Now, I hope you can see that. I can't see it on the screen here. We basically got 3 stable clusters. We did 3 different clustering methods and actually compared the clustering results from the same, and we found the same 3 clusters with 3 methods. Slight differences between, but actually the vast majority of patients fit into the same cluster each time. We then went on to look to see what the clinical differences were between these clusters. So we had a list of about 15 variables and saw if there were any difference just using ANOVA. See the differences between the 3 clusters, see if there's any biological plausibility. And 3 of the variables were different, and they all relate to each other. So oral steroid use was different between the groups, blood eosinophil count was different between the groups, and blood neutrophil count was different between the groups. Now they're all linked. Oral steroids put your eosinophils down and put your neutrophils up. So determining what actually the key factor is that's linked to this expression of disease is very difficult, and we don't know the answer from this study. These, of course, are just associations and not proving causality. But there's a biological story there that we're seeing in the breath, and we've done it in a completely unbiased manner, as we say. Secondly, we looked for correlation using regression analysis between the models that we found and the absolute blood eosinophil count and the absolute blood neutrophil count. Because just stepping along the little way towards proving causality, one of the things that can help there is instead of looking at it in a discriminant analysis, so just as a yes or no, you can look at it as a continuous analysis. And if you see a dose response between the variables that you're looking at, then that starts to make you think that maybe there is actually a causal link between the two. And sure enough, there was a correlation between blood neutrophil count, blood eosinophil count, and these compounds. So treatment monitoring, potentially a very important use for breath analysis in asthma, non-invasive treatment monitoring. Finally, special considerations for asthma. I guess I may need to jump over this, but it's really important. This is going to inform our methodology. When we did our original asthma and COPD studies, we made sure patients came in between 8 a.m. and 10 a.m. We just thought we'd control everything. We didn't really do it particularly because we were worried about circadian rhythm. But circadian rhythm is a really important thing in asthma and actually in health as well. We've done a study now looking at patients. So Hannah Durrington's an Asthma UK Senior Fellow. She's done a study keeping people in for 24 hours and doing breath sampling. She did blood sampling, did sputum sampling, exhaled nitric oxide every 6 hours over 24 hours. Lots of things are circadian in humans, blood cell counts, cortisol levels. And in asthma, your lung function's worse at 4 a.m. than it is at any other time. And actually sputum eosinophil count. So the amount of inflammation going on in the airways is worse at 4 a.m. than it is at any other time. So final slide. I've got the 1-minute warning. This is often what I put up as a final slide. We've got to take a lot of care with breath analytical studies. It's a big multidisciplinary specialism, which is why I really enjoy working in it. We have to take care of the environmental conditions, the clinical study design, everything. As Aggie said, validation, external validation of results is absolutely critical. But even that comes before, Stephen, forget that, we're still quite a long way from clinical effectiveness. That's the next stage after that, which we can hopefully start talking about in the future. And I think I'll finish there. I'll just put my acknowledgement slides. The teams and collaborators have grown a lot over recent years, so I'm grateful to all these people shown here and all the funders shown there as well. Thank you very much.
Excellent, thank you very much, Steve. So 5 minutes to questions, same deal as before. Over here.
Hi, thank you. Richard Lee, also a chest physician in London and Boston. I'm more interested in lung cancer, but I just wondered if you could elaborate on what you said about diagnosis, and sort of where the kind of the easy wins and the difficult areas would be.
Yeah, I think, for me, if we're looking at what's probably a result of a biological process, we've got to think back to where that's coming from. And a lot of the early lung cancer studies, a lot of lung cancer studies in breath, and obviously it's an attractive subject for biomarkers anyway, but they often have a healthy control group, sometimes even a non-smoking healthy control group, which is really problematic. So I think we have to just control as strongly as we can. And the place you need to sample for a lung cancer study is in the 2-week rule clinic, of course, and then you've got a natural case control group of exactly where you would use it. or potentially people being reported for abnormal x-rays. But then, you know, a potential issue with lung cancer is the different biology behind different types of cancer, metastatic cancer, central tumours versus peripheral tumours, people with systemic symptoms like wasting. Muscle wasting will obviously affect the breath profile as well. It's a very difficult area. It might be, you know, to me, I think looking at treatment response, early markers of treatment response might be more an easier hit, lower hanging fruit, because then you've got you changing a biological process or you're not. And they're a really well-matched group of patients. Same for asthma, really. I think that's where we should be looking.
Thanks.
Can you comment a little bit further on the drivers of those differences in Vox profiles between groups? You mentioned inflammatory status, drug consumption, and circadian rhythm. What about liver metabolic pathways, status, and microbiome? Can you comment?
Yeah, so there's so many confounders that we've got to look at in breath. So up till now, the vast majority of breath research has been discovery work, so unbiased, hypothesis-free, just looking, see what compounds are different between health and disease. And that's fine, that's what we have to do, and we still have to do that. But once we get to the stage, as I've shown for asthma, now we're getting some compounds, a table of compounds that are identified in different diseases, in different studies, then maybe we can start doing more targeted analyses and controlled studies that start to look for exactly those influences, to see what the differences are with time, with diet, with microbiome, with liver function, renal function, all these things. We don't know yet. We've not done big enough studies to control for all those things. And so the other thing is the other way of approaching it is just to take compounds that you know you're interested in and then look at how they're affected by those different situations. And we're not there yet.
Hi, my name is Christian Fritzer from the MRC Cancer Unit here in Cambridge. Maybe you say that, but do you know whether upon treatment with salbutamol and steroids, the signature metabolites that you see in asthma patients go down?
So we haven't yet done that. We're about to do that actually in a new so-called steroid-naive asthmatics who are giving controlled inhaled steroid to see what happens. So again, now we've got a targeted list. That's what we want to see. There are changes in the breath profile with and without steroids. There's literature on that already. But I would propose, I think the best way to do it is to look at a targeted list of compounds. Now we've got some and see how they change. You can titrate your methodology a lot better to do that.
I think it would be just interesting to see whether those metabolites are genuinely dependent on inflammation that is in the lungs or maybe something related to microbiome or other things.
Yeah.
Okay, excellent. Okay, one more question.
Hi, Donna Finch, MedImmune. I wondered whether anything correlated with pheno.
So in the circadian rhythm study, we've just looked at the pheno the other day actually, and when it looks like it might be slightly circadian, but we're not quite sure compared to other things. We've not yet looked at the absolute correlation between the compounds themselves. Pheno is another indirect measure of eosinophilic inflammation. It's likely that some things will correlate with it, I should think. I'm not sure what that means or whether that helps us, unless you're interested in a biomarker for pheno. But we wouldn't really need another biomarker for pheno. Pheno is already a great biomarker that you can measure non-invasively. We want to find something different. In a way, it's better if it's not correlated with pheno.
Excellent. Okay, so thank you, Steve, again.
All right, thank you.